You should see a prompt to click OK.
Yeah.
Okay. Hello and welcome to MedNews Week conference, where our goal is to bring you the most cutting-edge information from medicine's global leaders. I'm Gayatri Pramal and I will be your host for today. Before we begin, I want to first acknowledge the great team that helps to make these events a reality. Our founders are two internationally recognized researchers, Drs. Jan Leifman and Chandler Park, who is also the president of Kentucky ASCO. Our chairs include Drs. Park, Leifman, and Pratyusha Ganta. Our organizing committee is comprised of Alexandra van der Kieft and Dr. Yavuz Saleh. Our managers include William Wilkerson, Muskan Joshi, Pallavi Pai, and myself. Our educational committee includes Sean Jacovies, Amiral Shamon, Shubha Pawar, Janvi Shah, Madhuri Balasubramaniam, Choria Harshal, and Asta Nayak. The moderator for today's event is Muskan Joshi. Now to introduce our speaker today, Dr. Rohit Moudgil. Dr. Moudgil is an internationally recognized leader and researcher in cardio-oncology and the development of novel therapy integrating precision medicine in cardiovascular diseases. He is the Director of Consul Services in the Cardio-Oncology section. He is the Director of Cardiology Education Internal Medicine Residency Program. He is also the Assistant Professor at Cleveland Clinic Lerner School of Medicine and the Case Western Reserve University. He also currently holds secondary appointments as a consultant scientist at the NASA Human Research Program at the Johnson Space Center at Texas. Without further ado, it is my honor to welcome Dr. Moudgil. The floor is now yours, Doctor.
Oh, thank you. Thank you. Thank you for that kind introduction, and thank you for the invitation. I really, it's a true pleasure to be in this kind of forum. And today what we're going to talk about is the cancer and the cardiovascular disease. And my focus of the presentation will be how these two major diseases are intertwined with each other and how they actually are interconnected. So when we think of cancer and cardiovascular disease, they are very intertwined in a sense that effect on one of them actually cause implications on the other ones. And as the time goes on, it's becoming more and more relevant and apparent that cancer and cardiovascular disease are very, very interrelated to each other. We have made major strides in the treatment for cancer, and as the cancer survivorship is becoming more and more prominent, we are seeing much more of the cardiovascular disease. So it is quite apparent that there are two major diseases that causes death in our United States, and it is estimated about 18 million people are going to die with cardiovascular disease and roughly 9 to 10 million people with cancer worldwide. They are quite interconnected to each other, and I hope with my presentation I'll show some of the things. So because of this intertwined nature, there's an emergence of this field. It's called cardio-oncology. And basically what the field talks about is this emerging field of cardiology, where majority of our patient population are comprised of patients who are afflicted with cardiovascular disease secondary to cancer therapy. So this is one aspect of the things. And I will talk in detail about that. And our goal of our cardio-oncology is to treat, learn, and prevent cardiovascular disease as a competing cause of morbidity and mortality in our oncological patient while safely administering life-saving cancer therapy. So although I'm going to be talking about the cancer and cardiology, cardiovascular disease as intertwined, but cardio-oncologists are the people who are cardiologists who are actually helping patients get over their cardiac problems so they can continue with their cancer therapy, or they have received the cancer therapy and develop cardiac diseases and help to manage them. And this is going to be clear and present danger in the coming year. So 50% of the people have cardiovascular disease, 33% of the people have cancer disease. And so if you do the ratios, about 28% of the patient population that you will see in your clinic and patients inpatient setting, 28% of them will have both diseases. And as the time is going on, so this is the graph looking at the cancer survivorship and the projected time of 2040, about 26.1 million people will be cancer survivor as the time goes on. And our hope is that, like, what we are doing is, while we are extending life of our cancer population, we are not flipping this curve to the heart diseases and making it more and more prominent for patients with the cancer survive to actually suffer from heart disease, and as a result, they meet their early demise. And we already know that there's this thing called a late effect in our cancer survivors. So when you look at the cancer survivors, what we have found is that after the cancer survivorship, and you look at the general US population, there's about loss of life expectancy of 10 years. So just by being a cancer diagnosis as well as getting treatment of it, they are hampered by the fact that there's a late effect and they're losing about 10 years of their life. And on top of that, if they have cardiovascular disease, this margin widens as the time goes on. So what is with the cardiovascular disease and cancer? So when you look at cardiovascular disease and cancer, what we see is this: there's a lot of risk factors that are actually common, whether you look at age, sex, genetics, tobacco, and a lot of the other things, diabetes, hypertension, dyslipidemia, which are commonly associated with cardiovascular disease, are also actually interrelated with the cancer. And the list goes on and on as the time is going on, and we are finding more and more in this population. Oops. And this is the problem. Like, what happens with the cancer patients is that if they have cardiovascular disease, it remains untreated, and as a result, they develop more and more problems associated with it. So, for example, this is a graph taken from Mayo Clinic Proceeding by Al-Kendi, and basically what they looked at the prevalence of cardiovascular disease and type of malignancy. So, if you have hematological cancer, and it doesn't matter what kind of cardiovascular disease we're looking at, for example, coronary artery disease, cerebrovascular disease, carotid artery disease, heart failure, peripheral vascular disease, or any, about 33% of patients will have concomitant cardiovascular disease. The fraction is quite high if you're diagnosed with lung cancer, and about 43% of them will have concomitant cardiovascular disease. In breast cancer, the proportions are smaller at 17%. Colon cancer is 26%. Renal cell carcinoma is renal cancer is about 35%, and head and neck cancer is about 26%. So we already see that if you're diagnosed with cancer, there seems to be a proportion of the patients who already have a concomitant cardiovascular disease. And for different kind of oncological disease, there's different proportion of the cardiovascular disease. And they do affect each other quite a bit. So for example, this is a pictograph taken from the WHO. And what you look at is that 4.7% of the rate of heart attack or stroke are within 6 months of cancer diagnosis versus 2.2% participant who did not have cancer. So if you have cancer, your chance of getting diagnosed with heart attack or stroke is much, much higher. And this is just in the first 6%. There's 30% increase in death in lung cancer patient who has radiation shifted slightly towards the heart instead of to the right side. So not only that, the treatment itself can increase the cardiovascular disease. We know that if you exercise, for example, if you do 5 hours of moderate exercise per week before your cancer diagnosis, your chance of cardiovascular disease is 40% lower likelihood of cardiovascular disease event in patients who exercise regularly. And I'm going to touch base on that one a little bit later on. We have a lot of patients right now that they got diagnosed with childhood cancer, for example, lymphoma, they got radiation, chemotherapy, and they got diagnosed at age 12. I'm seeing them in my clinic at age 40 with heart failures. So there is a real danger associated with it. Going on with that, 25% of the patients with endometrial cancer survivors are diagnosed with cardiovascular disease within 5 to 10 years. And that statistic is pretty staggering also, because patients are generally slightly younger when they get diagnosed with endometrial cancer. And 87% of the proportion of women with breast cancer tend to have at least one cardiovascular risk factor, whether it's a hypertension, obesity, or hypertension, obesity, or diabetes, as some of them. And 43% of the testicular survivor tend to have a high blood pressure compared to 31% who do not have any cancer. So as the time goes on, not only we are saying that if you diagnose the malignancy, there's more incidence of cardiovascular disease. If you have cardiovascular disease, they tend to portend more incidence of cancer also. So, and that is just about the cancer itself, but what about the treatment? So this is a really nice picture of like starting from 1920s all the way to the 2018, all the medications or chemotherapies and things have been developed over a period of time. And this has been correlated over here. So you can see that initial chemotherapy, for example, anthracycline, which was actually developed as an antibiotic and turns out that it has an anti-tumor effect. It used to only cause cardiomyopathy, but not a whole lot. But as the time goes on, as we are developing more medication, for example, this is a targeted proteasome inhibitor, which can cause other things. For example, not only cardiomyopathy, but arterial vascular disease, as well as systemic hypertension. We're finding more and more neurochemotherapies, as well as immunomodulators. They're causing a lot more damage to the heart, all the way down to the CAR T cell therapy, which is a new one. As you can see, a lot of different systems are affecting. And now the problem is this, that about 6 chemotherapies are being approved every 7 days from the FDA. And all they have to show is that if the quality of life has increased, a little bit of survivorship is increased in 6 months. And therefore, we do not have a long-term data for what happened to the cardiovascular disease. And most of the time, what we find is that that only happens when patients are getting the medication in real world. And we find these kind of problems in the real world, like seeing the patients in our clinics or inpatient service also. So as the time goes on, not only the cancer and the cardiovascular disease are intertwined, cancer can beget cardiovascular disease can beget cancer, and now the cancer treatment can also cause cardiovascular disease. So the question is like, okay, so if the cancer treatment causing cardiovascular disease, why not just hold the medication? This is a study published in 2013. And basically, this is looking at one of the medications, one of the therapies we use in breast cancer, and that's trastuzumab. So trastuzumab has been known to cause heart failure. In most part, it is reversible, and sometimes it's irreversible. So if you hold this medication only for 4 weeks, just for 4 weeks only, your chances of overall survival decreases by 15%. And that's a staggering statistics. That's only delay of trastuzumab for 4 weeks. And if you extend it further, and this was published in JAMA Oncology in 2020, and basically what they looked at was one group was called continuous therapy, which received about 108 doses of cumulative doses of trastuzumab, and interrupted, which got only 81 doses of. There was a staggering difference in terms of survival over 10 years of age. And when we look at just at the 6 years, about 56% more patients died in interrupted group rather than the continuous group. So again, showing that just stopping the medication is not the answer to the problem that we are facing right now. So coming back to it, so I showed you that the cancer begets cardiovascular disease begets cancer. There's a lot of factors that are intertwined to each other, like that makes cancer and cardiovascular disease a common enemy to us. And while we are doing much better in cancer therapy, what is happening is a lot of these patients are developing cardiovascular disease and flipping the curve, and they are dying from cardiovascular disease. So the question remains is how they are intertwined. What is the thing that is causing both of these two diseases to be interconnected to each other? So one of the ways they are interconnected is at the level of inflammation. So on your left-hand side, you'll see the innate and adaptive system in cardiac disease. So it doesn't matter what kind of cardiac disease you develop. So for example, if you have ischemic cardiomyopathy, toxic cardiomyopathy, peripartum cardiomyopathy, what happens is it results in immune activation, okay? So in an innate system, that can cause toll-like receptor activation. It can cause other kind of chemokines and inflammatory cytokines like IL-1, IL-6, IL-8, and TNF-alpha also. And what it does, it causes increase in inflammation. In the adaptive side, you have B cell and T cell. These get activated, for example, cytotoxic CD8 cell or helper CD4 cells, they get activated, and they can cause endothelial dysfunction, and that can result in eventual heart failure. When you look at the cancer, a similar mechanism is taking place. And case in point is that now one of the major therapies we use for cancer treatments, immune checkpoint inhibitors. And they basically rely on the fact that we have to activate the immune system in order to kill our own cancer cells. And in this case, for example, what happened is that there's a lymphoid cells that actually downregulate some of this inflammation that is targeting the cancer cells. As a result, the cancer can proliferate and they can cause damage to the body. And what happens is that our body has homeostasis involved, in which the cells normally grow, and if there's inflammation, it gets regenerated, and that's the cycle happens. However, in certain situations, they escape this cycle and they develop into tumor genesis and then causes cancer. So inflammation plays a very common role between two of these disease processes. And when we look at the cardiovascular disease, there was a big trial done by my good friend, Dr. Paul Redker in Brigham and Women. And it was looking at IL-1 alpha inhibitor, and it showed that if you have increased inflammation, actually it decreases your mortality for cardiovascular disease. And statins were really, really helpful in that kind of setting. So we are already finding a lot of inflammation in cardiovascular disease, and it's already well established in the cancer world that the inflammation does play a major role. Beyond the immune system, there's other system also play in the role. So mainly, for example, this is looking at the hormones. So this is looking at the adipose tissue. So you're looking at the adipose tissue, and if it gets activated, a lot of other things that I mentioned previously, for example, TNF alpha, interleukin-1 beta, IL-6, they get activated. And if they get activated over a period of time, what happens is that there's some hormonal thing actually causes systemic inflammation, causing increased endothelial permeability, causing plaque development. It can decrease cholesterol metabolism and increase glucose production and insulin resistance, causing cardiovascular disease. And not only that, it can lead to diabetes, which is a major risk factor for cardiovascular disease. And when you switch to the right side of the screen, which is looking at the adipose tissue is very, very helpful in terms of causing distant metastases, and not only that, promotes the growth of the cancer cells. What happens with the decreased insulin sensitivity is that you actually produce things like ILG, insulin growth factors, which actually can cause increased proliferation and high invasion and high migration of these cancer cells. And that can result in increased cancer phenomena. So there's a lot of factors that are common between these two disease processes, so namely inflammation and at the hormonal level. And as the time going on, that we are finding more and more of these things. But the trouble is that once we start working with the cancer and cardiovascular disease, they can also cause formation of vicious cycle. So for example, what happened with the cancer cells is that when you have cancer, they're trying to promote the growth of blood vessels so that they can, the blood vessels can act as a conduit to have a distant metastases. And so what happened is the hypoxia-induced angiogenesis causes increase in hypoxia-inducing factor, VEGF, things like that. And we use TKI inhibitors or VEGF inhibitors to stop these kind of things. But these ones are actually cause cardiotoxicity. For example, a high rate of high blood pressure increase and other direct effect on myocardium, causing heart failure. And when you have ischemia, there is a decrease in VEGF, and that causes a stimulation of the VEGF, and that promotes tumor growth. So by intervening in the cancer itself, we might be inadvertently making the cancer growth happening more and more. So that is a real and present danger also. And we know that as the time goes on, a vicious cycle sets up where the treatment of the cancer or the cancer itself can cause cardiovascular disease, and the cardiovascular disease itself can promote cancer growth. So as I mentioned at the start of the talk, they are conjoined twins. They are connected to each other in various ways, either when you're looking at the shared risk factors, the clinical presentation also, various cardiac matrix that also provide the fodder for the cancer growth, the tumor stroma, the microenvironment, the angiogenesis, as I mentioned, inflammasome, all these things actually cause the formation of these two processes to be a conjoined twins. And we'll talk a little bit of the drugs itself, how they can help try to minimize this progression of the cycle, but that's where we are at right now. So this is the more of a biology of the heart failure and the cancer, but it goes one step further. And when I say one step further, we have this thing called cognitive distraction. So when a patient gets diagnosed with cancer, what happens is that the treatment gets very focused on cancer itself, and all the other things takes the back seat. So for example, if the patient has a high blood pressure, it doesn't matter. A patient needs a cancer therapy right away, so they're getting the cancer therapy as it is, and so on and so forth. So a lot of things get missed during the diagnosis of the cancer and the treatment of the cancer. And for example, if they're feeling fatigue, which can be a symptom for cardiovascular disease, however, it is also chalked up to the fact that, oh, it's probably due to the cancer therapy or the treatment itself that is causing all these things. So there's a lot of things that can happen with cognitive distraction. And here's a gentleman who's looking at his cell phone who can fall in the abyss, in the canal, and just by the fact that we are concentrating on a small thing and not looking at the big picture around us. So, and this is quite evident, and we have found in the real population, real life population also. So for example, when you look at the hematological patients, and if they have any kind of cardiovascular disease, only 51% of them are on antiplatelets, for example, aspirin. Only 47% of them are statin beta blockers, ACE inhibitor, and only 50% of them have a cardiology appointment. And that is not only limited to hematological cancers, but all across the board, we see the similar statistics in terms of only about 50% of them getting treated, and only 50% of them are seeing a cardiologist for their cardiovascular disease. So a lot of the things get missed. And what is the result of it? So this is a paper published in European Heart Journal in 2019. And basically, it looks at the risk of death from heart disease in the patients who got diagnosed with an oncological problem. So this is standardized mortality ratio for cancer. And basically what happens is that once the cancer treatment starts happening, there's a decrease in the rate of heart diseases in all of them. And the reason being is that because everybody is very vigilant when they're getting treatment. For example, if there's changes in ECG, they get referred to cardiologist, or the blood pressure is really going, patient had hypertension, now they are on tyrosine kinase inhibitor, and now the blood pressure is really going high, they get treated for that. But once they have survived the cancer, there has been no real management by the cardiologist, and they often send to their own PCP. And sometimes those things can get missed. And what we have found that over a period of time, and this 120 months, which is 10 years, we see increase in the heart diseases in all these other cancer and all sites also. So what we are seeing more and more now is that once they get diagnosed, there may be a transient decrease in heart disease, but over a period of time, we do see a lot of it. And this has been recognized by big authorities such as the European Society of Cardiology. So European Society of Cardiology is the first society that actually came out with the guidelines on cardio-oncology. And this is fresh off the press. This was just released 2 weeks ago in Barcelona, Spain. That's where the conference happened. And basically what they came up with is that there's a continuum, there's a dynamics of cardiovascular toxicity risk of patient with cancer over their therapy continuum. So when you look at the baseline and you see in the patients the baseline, no matter where they are, either they're high risk or low risk, our strategy is to try to decrease the baseline as further down as possible. So even if they are low risk, for example, their LDL is good, they are not diabetic. However, if they are not exercising, we should promote that they should exercise so that, you know, they are even at a lower risk than what they are at currently right now. And we know when they start the cancer treatment, no matter what, if they are in low risk or the high risk, right, the curves do go up high. And our job as a cardio-oncologist or any kind of a healthcare provider is to decrease this curve as the time goes on. And when the cancer survivorship is going on, it becomes even more important to continue to decrease these curves as the time goes on. So this is the first figure in the European Society of Cardiology, indicating how important it is to recognize the cardiovascular risk factors in the patients who have cancer and try to decrease as much as possible so that they can live a cancer-free as well as cardiovascular-free life, okay? And in cardio-oncology care pathway, what we are saying is that there's a new cancer diagnosis and all the way to the long-term follow-up. First of all, have established a baseline of cardiovascular toxicity risk assessment, and then look at the low risk, moderate risk, and high risk. And if they are high risk, we have to follow them much more closely with the cardiology follow-up, as well as transthoracic echocardiogram every 1 to 3 years and every 5 years, and annual cardiovascular risk factor assessment. So for the low risk, you can go for 1 year assessment and just standard surveillance, and probably for moderate to severe. For high risk, a cardiology referral is warranted. And the thing is, at any time, if they have developing some kind of cardiovascular disease, cardiologist or other healthcare providers should be involved in their management. And thing is, so when you look at the baseline cardiovascular toxicity risk, there's a lot of things, and the whole process should involve the clinical assessment, looking at the cancer treatment history, cardiovascular history, the risk factor management, physical examination, vital signs, and we have to do this complementary test in order to figure out what are the baseline CV toxicity risk assessment checklist and find out what is the baseline risk factors are. No, sorry. And as the time goes on, we have to keep reassessing the risk. So if they are the likelihood of the cancer therapy related cardiovascular toxicity, if they are low, we have to constantly look at it. If they are going from low to intermediate or high, and try to follow them as much as possible as the time goes on. And once we have looked at the baseline cardiovascular toxicity, we have to look at their cancer history, the cardiovascular disease, and we have to do all these testing and things so that we know where the risks are and to follow them appropriately as the time goes on and refer them appropriately when things happen. But unfortunately, what happens just in normal life, a lot of the times the primary prevention is missing. Patients get diagnosed with cancer, they get treatment for cancer, all they develop high blood pressure during the treatment, and was prescribed, for example, some kind of antihypertensive, but there's no follow-up after that in terms of what's going on. So what happens is that because of the lack of the primary prevention, we have to do a lot of secondary prevention. But as I mentioned, since the cancer and cardiovascular disease are so intertwined, it is not now hard to believe that if we start treating patients with cardiovascular disease, we may garner some benefit from the cancer front also. And this is becoming more and more apparent as the time goes on, that we are seeing that with typical cardiovascular medications that we use on everyday basis actually has beneficial effect in the cancer world also. So let's start with aspirin. So aspirin is one of the first medication that was approved for cardiovascular disease back in late 1980s. And right now it is used for all the cardiovascular diseases. For example, if you have coronary artery disease, if you have diabetes, and have hypertension, aspirin is being used. And the reason being is that no matter any kind of major coronary event, any stroke, any vascular disease, any vascular event, it is very, very cardioprotective as well as protective for the cardiovascular disease. But it's becoming more and more apparent that aspirin has much more bigger role to play just than in cardiovascular disease. This is looking at aspirin in various kind of cancers. And this was published in Lancet Oncology in 2012. And one of the things that it really pops out is that when you look at the colorectal cancer, aspirin seems to be very, very beneficial in these patients. And it turns out that aspirin not only has antiplatelet activity, but it does have some anti-metastatic activity, especially in the colon cancer. And we're finding more and more that if you're diagnosed with the colon cancer, aspirin has been very, very useful in these kind of settings. So, and thing is, this not only goes just at the time of diagnosis. So this is the data risk of colorectal cancer, 10 to 14 years after randomization, patient who got aspirin and no aspirin. So patients who were on aspirin for cardiovascular diseases, and they looked at patients who were not on aspirin for any other reason. And when you look at them over 10 to 14 years and to see who developed colon cancer or not, the people who are on aspirin, which is blue line, tend to have lower colon cancer over 10 to 14 years than the patients who were not on aspirin. So it shows that not only aspirin is beneficial during the treatment of colon cancer, it can actually reduce your risk of developing colon cancer over a long period of time. And so the thing is, and this is looking at the rate of death from colon cancer, according to the frequency use of aspirin after exclusion with selected illness. And selected illness is defined by cancer, heart disease, or stroke in this cohort. And what we find that people who are using more and more therapy or aspirin, their risk of death from the actual colon cancer is quite low. And this is significant across men and women, and it doesn't matter if they were it's both in men and women. So this is a staggering result. So aspirin seems to be beneficial in not only preventing colon cancer, it might be beneficial during the treatment of colon cancer. And not only that, also the more you use the aspirin, the better it is for the colon cancer. So be mindful, these are like preliminary data only, and there's more to be built up, but the use of aspirin in colon cancer has been well recognized. So what about the ACE inhibitors? So ACE inhibitors are used a lot in our cardiovascular diseases. So for example, it is used in stable atherosclerotic disease, post-myocardial infarction, patient with heart failure with reduced ejection fraction, and a little bit also preserved ejection fraction. They play a major role in prevention as well as management of cardiovascular disease in our arena. So when you look at what are the role of ACE inhibitors in cancer population, so we already identified, and this is a very small picture, I don't know if it projects very well, but we have identified ACE enzymes as well as the angiotensin receptors type 1 and type 2 on various cancer patients. And the thing is, it has turned out that the incidence of cancer is quite low if they get treated with ACE inhibitor rather than no ACE inhibitor. And it doesn't matter what how you manage the hypertension, but if you have an ACE inhibitor, there seems to be a decreased trend towards development of the cancer as the time goes on. And not only that, not only the incidence is kind of low with the ACE inhibitor and other antihypertensive, but the rate of death from fatal cancer is also low if you're on ACE inhibitors compared to not being an ACE inhibitor. So the ACE inhibitors seems to be also protective in this patient. And this is not hard to believe. We know with the ACE inhibitor is that one of the things angiotensin converting enzyme does, it increases your TNF alpha quite a bit. And we know this from the preclinical trials that the ACE inhibitor causes increase in TNF alpha. So as I mentioned before in our section of inflammation, so if you decrease the TNF alpha, that might be beneficial in prevention of the cancer. And right now we do use a lot of immunomodulator or immunotherapies, which actually reduces the TNF alpha. And this is a graph from published in European Heart Journal 2022. And basically it shows that the ACE inhibitor with the combination of beta blockers are very helpful in patients who have breast cancer and getting treated for both anthracycline and trastuzumab. The ejection fraction actually improves with the addition of both of them. So switching gears and looking at beta blockers. So beta blocker is a mainstay therapy for cardiovascular disease. So it doesn't matter if you have a high blood pressure, if you have myocardial infarction, heart failure, beta blocker is a mainstay therapy for cardiovascular disease. So this is some of the data that was published in Cancer World. And Dr. Sood, who is in MD Anderson, does a lot of work with beta blockers and looking at the cancer itself. And this is just fascinating. So this was published in Nature Medicine. And basically this one looked at the tumor weight and the nodule itself. So if you increase the daily stress, it turns out that the tumor weight and number of nodules increases. And it doesn't matter which line of tumors you use. And thing is, if you use beta agonist, it again increases the tumor weight and nodules. But as soon as you start using the blockers, for example, propranolol over here, or you add propranolol to daily stress, it actually decreases the tumor size and number of nodules. And this has been shown in multiple cell population in the Petri dish that the beta blocker is really, really helpful in these kind of setting. So preclinical model is very, very powerful in this setting. But not only that, we also find that with the breast cancer survivor, if you're on beta blocker, this is one of the study published in OncoTargets, the patients on beta blocker tend to survive much, much higher than the other patient. And the one on the right side is looking at the prostate cancers of patients who are on beta blocker. The percentage of them alive over a long period of time in months and 10 years is much, much higher in prostate cancer compared to the patients who are on other medications, which were not on beta blockers. So it appears that not only in the preclinical model, but also in clinical model, the beta blocker is very, very helpful. But unfortunately, what happens is that once you find good thing in one thing, you start using for everything. So these are various clinical trials which was published on beta blockers, looking at like efficacy of beta blockers. But because it has been used for so many different cancers, and turns out that it may not be beneficial in all the cancer, and that's why it is not being currently used as an adjuvant therapy with a lot of the other cancer. But we believe, and we are doing active studies on it, that beta blocker in certain cancers is actually very, very beneficial. And we are looking at those specific cancers and see if we can incorporate or repurpose the beta blocker use in those cancer, because we know what happens with the adrenergic system is when the adrenergic system gets up, it's easier for the cancer to metastasize and localize in other places. So it's really, really cardioprotective in that sense, and not only that, protective for the cancer patient also. So the second last we are looking at is the statin. So statin has been used for primary prevention as well as secondary prevention in cardiovascular disease. And when you look at the statin use, we know this is in the prostate cancer mortality. Statin seems to be beneficial in the prostate cancer. Not the early form of prostate cancer seems to be benefiting from statins, not the prostate cancer. We tend to be late and aggressive. Statin doesn't seem to work in that kind of setting. And this is the statin risk of gastric cancer. Again, it is protective in that kind of setting. But one of the major places where it is really protective is the breast cancer. And especially the data on triple negative breast cancers of patients who are not ER positive, who are not ER2 positive. Those HER2 positive or ER and PR negative, they tend to garner a lot of benefit from statins. So I personally have a lot of patients who have triple negative breast cancer, and they are on statin because it's very, very helpful in protecting from cancer as well as the cardiovascular disease. And this is bringing up at the end of like the hub of the whole thing. So this is a paper that was published in Nature in 2020, November 2020. And basically what these investigators looked at was how PCSK9, which is actually a inhibitor we use a lot to decrease your cholesterol level, how it actually increases the immune checkpoint inhibitor potency. So PCSK9 is a receptor that is present on top of the cells. And it turns out that when this PCSK9 is activated, what it does is that when it is activated, it actually activates T cells also and causes a lot of activation of cytokines. What we have found is that, what they have found in this paper is that when you inhibit PCSK9 and give them immune checkpoint inhibitor, the actual activity increases quite a bit, and they respond much, much better. Clinically, since then, they have a lot of other authors have identified that if you have PCSK9 antibodies, the more antibodies you have in your serum, the better you actually respond to immune checkpoint inhibitors. And as you know, immune checkpoint inhibitors are currently being used for 50%, or roughly half of different kind of cancers out there. So that's really, really important. And the thing is, it's not only that, if they have a decreased PCSK9 receptor, they actually respond much, much better to immune checkpoint inhibitors. So it's becoming more and more and more apparent that these two entities are intertwined with each other. Last but not the least is the exercise. So exercise is a cornerstone of cardiovascular management. So for example, if you get the valve change in the cardiology, if you get bypass surgery, or if you even get a stent put in, or even if you're just coming with chest pain, which is unregulated with the medications, cardiac rehabilitation is a cornerstone of our therapy. And we know that because when you look at the exercise-based rehabilitation versus usual care hospitalization, the favor of the cardiac rehab is much, much higher. And this goes on for not only for the mortality, this is mortality, and this is hospitalization, this cardiovascular mortality. It is beneficial in both settings. And actually, what we are finding is that this is really, really beneficial in our cancer population also, to the point that in clinic, we are siphoning a lot of these cancer patients through our cardiac rehab and garnering benefit for them. So the problem is that, like, when we look at the patients in cancer, right now, what they happen, there's a heterogeneous population and everybody's getting prescribed the same prescription. And as a result, the chance of non-responder is much higher than the responders. What we do in cardiology is that we look at the population and we divide the population based on like their characteristics. And based on that, we write the prescription. And that prescription is different for each and every individual. And what happens is our proportion of responders are much, much higher than the non-responders. So if we take our oncological patient, go through the same process of identifying the risk, identifying what are the things they require, writing the individual prescription for individual group, what do you find that we are getting a lot more benefit than your garden variety physical therapy. And the process goes like this. So ASCO cardiotoxicity guideline, patient receiving high dose of anthracycline, the standard exercise. So these are the things we are looking for. And if they have done CPAT, we can identify what are the things that is, and we're looking at the multi-dimensional data. If they have glucose intolerance or they're obese and things like that, then we do targeted dosing of these are the things we're looking to reduce. And if we do this targeted prescription, we find that they are doing much, much better in terms of the overall profile. So much so that there's a push for what's called core or cardio-oncology rehab, in which we are taking oncological patients, putting them to cardiac rehabilitation, and it is going very, very well. To the point that patients who have stem cell, bone marrow stem cell implantation, what we have been doing is taking those patients before the bone marrow stem cell implantation, putting them to cardiac rehabilitation, and midway they're getting the bone marrow transplant and putting them back on the cardiac rehab, and they fare much, much better in terms of reduced hospitalization and improved implantation of the bone marrow cells than the other cohorts. So we are finding more and more of these things. So as the time goes on, it is very apparent that the exercise should be the part of the regimen. We push that for our cardiovascular patients, and we should have the same thing for our cancer patients also. So in the end, what I want to say is that all these things are interconnected, whether you have breast cancer or lung cancer or any kind of sarcoma or mandibular cancer, anything, all seems to be interconnected somehow. And all these things are leading to the heart one way or another. And that's what we have been finding through the research that we have been doing, as well as what we are finding in our patients. And so what the future holds is this. So once we identify this connection, I think the future is bright, because what we can do is, if we look at the history and learn the lessons from then, we can apply to the future, and that way the future will be bright. So the past is where you learn the lessons, and the future is where you apply. And hopefully we are doing that as the time goes on. Thank you very much for your attention. And I'm open for Q&A. Thank you.
Thank you so much, Doctor. That was an amazing presentation. We have a large number of attendees who have enjoyed your great talk and are now eagerly excited for the next portion of today's event. So now I turn over the microphone to our amazing moderator, Muskan Joshi, over on Clubhouse for the Q&A portion of today's presentation. Over to you, Muskan.
Thank you so much, Dr. Moudgil, for such an amazing.
Oh, thank you. Thank you for having me.
To Dr. Rohit Moudgil. He is the Director of Consult Service, Cardio-Oncology Section, and the Director of the Cardiology Education Internal Medicine Residency Program at Cleveland Clinic. He is also a consultant scientist at the NASA Human Research Program at the Johnson Space Center in Texas. We have received a lot of questions and will do our best to get to all of them in the time that we have here with you. So for the first question, I will be passing the mic back to Gayatri.
Yes, Doctor. So my question to you is that during the peak of COVID-19, inevitably we had to take that as the primary point of concern and treat patients for COVID-19. So in this scenario, the treatments for oncology and cardiology took a backseat, and this could be detrimental to the patients. So I was wondering, how did medical practitioners combat this and deal with the situation?
So that's a really good question. Actually, we published a paper with my good friend, Dr. Sadler from Florida in Cleveland Clinic, Florida. And basically what we found was that like the access to the care was quite limited during that setting, especially for the cardiovascular disease, as well as the cancer care. And as a result, there was a lot of patients who met early demise because of that. Because of the restricted care, that's what happened. And not only that, um, because of the COVID-19, there was a decrease in physicians also in terms of a lot of hospitals let go of the physician, and as a result, the care provider were also limited. So overall, there was a very negative impact on the overall system, and as a result, our cardio-oncology patients suffered the most. And this is very nicely illustrated. We did a worldwide paper on that one. It was published in Frontiers in of Cardiovascular Medicine by Dr. Sadler, Sadler, and we found that it had a greatly negative impact on it.
Thank you so much, Doctor.
Hello, Dr. Moudgil. So for the next question, I will be going ahead. So my question to you is, I had read that you have worked in, you are currently working as the NASA Human Research Program. So I wanted to know, how has working in this field impacted your clinical practice? I would love to hear more about your experience in NASA's health research program. Thank you.
So basically, one of the things we look at the patient is also the radiation itself. So we know the radiation affects the heart, and there was a landmark paper published in 2011 by Sarah Darby, where we looked at the patients with breast cancer, looking at the right versus left, who got the radiation treatment. And we know one gray increase of radiation to the heart increases your risk of cardiovascular disease by 7.4%. So we know radiation plays a major role. So as the NASA is embarking on stationing some of our astronauts in Mars, we are looking at the fact that, you know, we're going to be outside of this thing called Van Allen belt, which is actually protecting us from cosmic rayses and galactic rayses. So we're going to go to the outside of that belt, and we're going to be exposed to what we call a high linear energy transfer molecules. For example, your protons, neutrons, and carbons, those kind of things. The problem with those radiation is that once they hit a photon, once they hit the photon, more photons are generated, and as a result, there's an amplification phenomena in terms of radiation. So our job as my job as a cardiologist and physician here is to actually advise them what are the things we can do to mitigate the radiation exposure. We cannot use things like lead or anything like that. Actually, it would be detrimental because the lead will itself expose much more radiation to the astronauts. So we are working in conjunction with NASA to how to mitigate these risks. And if there's other things, for example, statin use that has been shown to mitigate some of the radiation can be helpful in that setting. So we're exploring that aspect of it.
Wow, Dr. Moudgil, that was absolutely amazing to hear. And thank you so much for that answer. So for the next question, I will be passing the mic over to Rabab.
Hello, doctor. So I'm Rabab. I'm a fourth-year medical student. And thank you so much for your wonderful lecture on cardiovascular diseases and oncology. And them being twins was an amazing aspect to hear too. And it was really amazing for us being medical students to have a clear understanding of the pathogenesis treatment and the toxicities of the treatment. And so my question to you was, what is the current reported lifespan of patients developing cardiovascular diseases after cancer therapy? And what is the therapy currently in use to increase the lifespan? Thank you.
So that's a good question. So the thing is, it depends what kind of therapies you use. First of all, what kind of cancer you have, number one. Number two is what are the therapies you're receiving. And number three is like it's pretty specific in terms of the therapies you receive and the treatment you need. For example, anthracycline causes cardiomyopathy, but that cardiomyopathy can happen in 5 to 10 years down the road. So if somebody is exposed to anthracycline, probably follow up with the cardio, like your family physician, and if something happened, follow up with the cardiology is very, very important in terms of getting your risk stratified for developing cardiomyopathy as the time goes on. But for example, if you're on other medication, for example, arsenic, that causes a lot of QTC prolongation as well as bradycardia. So that is much more of an electrical problem. If you have CLL, you get treated with this medication called ibrutinib, which causes atrial fibrillation, and the management of the, so you have to make sure that the patient doesn't have a high atrial rate before the treatment, so that you can decrease the atrial rate, and that will not predispose the patient to develop atrial fibrillation. So it's a pretty wide field, and there's a lot of things that we know, but there's lots and lots of things we don't know. So it depends on the therapy itself, of what the therapy patient is getting and how we're going to mitigate their risk with the therapy.
Thank you so much, sir, for that wonderful insight, and it was really great to hear from you.
Thank you so much, Dr. Moudgil, for that wonderful answer. As Rabab just mentioned, that was really, really insightful. So for the next question, I will be passing the mic over to Madhuri.
Thank you so much, Doctor, for this really great session. And I learned a lot from what you had spoken about. So my question is, how do you assess or consider the risk to benefit ratio of continuing a chemotherapeutic drug in a patient who can develop this drug-related cardiac dysfunction?
So that's a really good question. So it depends, again, on the therapy. So for example, as I mentioned in the presentation, trastuzumab is really, really good medication that if you hold the medication for 4 weeks, your chance of increased death from the breast cancer itself is 15%. And if you truck it along to about 6 months, it's about 56% increase in death rate. So for example, if the patient needs trastuzumab, we try to do our level best to actually control the cardiovascular risk as much as possible. If they have developed cardiomyopathy, have a frequent follow-up, and making sure that they are taking the medication, and be on top of their treatment, on top of their cardiovascular disease very, very strongly, so that they still can get trastuzumab and garner the benefit from it. But other medication, for example, if you're on doxorubicin, which is an anthracycline, if you develop cardiomyopathy due to doxycycline, then we liaison our oncologist and see if they can be on some other medication, for example, epirubicin or idarubicin, and see if that is a beneficial aspect to that. And we do that quite a bit. For example, for colon cancer, patient receive 5-FU, 5-fluorouracil. Now, the thing with the 5-fluorouracil is that 20 to 30% can develop some form of toxicity with that. And we found that switching them to capecitabine Xeloda, which is an oral formulation, the risk is much, much reduced, although the efficacy might be reduced for the colon cancer. But the cardiomyopathy is certainly mitigated in that kind of thing. So it depends on individual patient, and we liaison with the oncologist and try to come up with the best possible scenario when we treat the patient, so that we can manage the cardiovascular disease and the oncological disease at the same time.
Thank you again, Dr. Moudgil. That was an extremely insightful answer. So for the next question, I'll be passing the mic over to Astha.
Hello, Doctor. That was a very insightful presentation by you on cardiology and oncology. It was a very different experience for us to hear about it. My question for today is, despite the challenges of cardiology, what are you most excited about the future of this field?
So that's a really, really good question. So the thing is, what I'm excited about is the information that is coming out with the use of oncological medications and cardiovascular disease. So for example, when you look at the cardiovascular disease, we have over 5 to 6 medication that we use now, right? So you have your aspirin, you have your antiplatelet therapy such as Plavix, you have beta blockers, ACE inhibitors, statins, and PCSK9 inhibitors, and now more recently the GLP and the SGLT2 inhibitors. Those are the medications we use only in cardiovascular disease. Now the thing is, but there's still areas in the cardiovascular disease which remains unexplored in terms of like, we still don't know how to treat them. So for example, diastolic dysfunction, more than 55% of the patient with heart failure actually has some degree of diastolic dysfunction. And thing is, we do not have good therapy. And more recently, there's a publication on the SGLT2 inhibitors, which might be beneficial in that one. And if you believe spironolactone trial, there's a TopCat trial, spironolactone may be beneficial, but we still don't know the mechanism of the diastolic dysfunction. So we did a research in which we showed that anthracycline can cause topoisomerase 2 beta inhibition. And actually what we found was that enzyme causes diastolic dysfunction. So that was unbeknownst to us before, that enzyme can play a role in diastolic dysfunction. So what I'm excited about is the uncovering of the mechanisms. So when we treat a patient with oncological medication, we are honing into the areas that the cardiology hasn't explored yet. And because we are identifying those kind of areas, we might be able to mitigate cardiovascular disease in the patients who do not even have cancer or have cancer. So that's what I'm very, very excited about now in future, because there's these unexplored mechanisms which are coming up with the help of all these oncological medication. And that's what I'm excited about. Yeah.
Wow, Dr. Moudgil, thank you again for that wonderful, wonderful answer. So I actually had another question. You are also an educator. Can you discuss the synchrony between high quality patient care and also educating the next generation of physicians, researchers, and physician scientists? I would love to hear your thoughts on this.
I mean, in order to progress any kind of field, you have to make sure that the, people behind you, people with you, and people in front of you are, getting are educated and, providing a good care for the patient. And as the time goes on, the technology changes quite a bit. So I'm from the era where my preceptors used to rely on clinical examination quite a bit. Listening to the stethoscope was a major way to diagnose the disease. And when I was training back in late 1990s, well, not late 1990s, more like in 2010s kind of thing, what happened in the training program was like we were emphasized that listen to the heart and things like that. And now the current generation is such that they're looking more at echocardiography as way to diagnose disease. And, we are foregoing of some of the clinical practices we used to have. In future, I don't know what the future holds. I think it would be a tricorder where we just scan a person and we don't have to do anything. We don't even have to talk to a patient, walk away and diagnose the disease. So I think as an educator, our goal is to make sure that we use every possible tool that we have at our disposal to use it to diagnose the patient and treat the patient accordingly. And as an educator, I try to stress that in my residents and fellows that we have to use all the tools. And teaching is the best form of learning also. So if you're an educator, if you're a teacher, you have to make sure that you are up and up on your clinical trials and you are up and up on your skills and what is up and coming. And I think that also keeps you current. So I think being an educator is the most important thing you can do in life, because not only makes you current, but it keeps you humble and it keeps you practicing in a very humble way. And I think that's what the role of educator is.
Definitely, Dr. Moudgil. That was yet another amazing answer. Thank you so much for that. So for the next question, I'll be passing the mic over to Dr. Yan.
Thank you so much for that great presentation. For patients undergoing anti-cancer therapies, how do you envision care changing with respect to the growing field of cardio-oncology? And at what stage should cardio-oncologists be on board? Thank you.
Yeah, that's a great question. So the thing is, as the public and everybody's getting more illuminated about cardio-oncology, we are seeing much and more referral coming in our way. And not only that, now the patients are asking for cardio-oncologists to be part of their clinical care team when they're undergoing oncological therapies, especially with the medication that have cardiotoxicity associated with it. So I think, getting them more and more involved and getting the patient out there to be involved, I think that is the major thing that is going on in terms of, getting that cardio-oncology initiative out there, as well as, so that people are aware, the awareness of cardio-oncology. And thing is, as the time goes on, what we are doing is also trying to learn from these patients also. So I'm going to do a small plug-in, and this is for the, myself and Dr. Sadler, as well as Dr. Arko Teske in Netherlands, and Dr. Sadler, he's in Florida Cleveland Clinic. We have started a global cardio-oncology registry. So basically it's 130 institutions signed on the dotted line that they will put all the patients in cardio-oncology in our registry. And there's 24 institutions all across the world which are signed up with us, 24 different countries and 134 institutions signed up with us. And what we are doing is trying to get these patients enrolled in registry, learn from them, learn from different practices. For example, we have a big consortium in Australia, Brazil, Argentina. So they differ in practice, and we also have people in Turkey. So every place differs in practice. So learning from them, what is the best way to practice, and trying to apply that to the patient, to oncological patient, and the cardiac care to oncological patient, I think will be the thing of the future. So those are the things we are doing right now. So in terms of answering your question, so if we know what they're getting treated with, getting involved in early care, and during the care, like if they find out any problems with the cardiac institution or secondary prevention with cardiac medication, will be also helpful in these patients. I don't know if I answered the question. So
it was perfect. Thank you so very much.
Okay, I just went on a tangent and then tried to come back. So yeah.
Thank you, doctor, again for that wonderful, wonderful answer. So for the next question, I will be passing the mic back to Rabab.
So doctor, what is one of your biggest career challenges and how did you overcome it?
Career challenges. The thing is, yeah, like when I look back on my career, a lot of things have been challenging. Going through med school is challenging, doing the residency is challenging, balancing the family life and residency is challenging. So I think, like, personally, I don't find like like balancing the academic career with your family, that can be very, very challenging, because you want to be present for the family, but you also want to be there for the patient. So I think the most challenging aspect is to find that balance between the family and the work world. And thing is, I still face that challenge on an everyday basis, and I don't think so I perfected that still. But thing is, it's an ongoing challenge, and I'm still learning on that one. So I think for me, that has been the biggest challenge, and it is still ongoing.
Definitely. I really believe that problems and career issues definitely do arise over time, but it's all about how you overcome them. Yeah, thank you so much again, Dr. Moudgil, for that wonderful answer. Madhuri, I will now pass the mic over to Madhuri for the next question.
Thank you so much, Doctor. My question is, for our junior attendees over here, looking for mentors, what advice would you give them?
So the advice for the mentor is that always seek out the mentor that, is willing to help you, right? Not the mentors who are looking for, extracting work out of you and, try to, gain, they're not using you as a stepping stool to further their own career, right? So you have to always look at the mentor who are like self-sufficient, and not only that, they're at that stage of the life that they're comfortable with who they are, so that they can be a great teacher for you and they can help you in your career. So the thing is, finding a researcher is easier, finding a mentor is extremely hard. So the thing is, there's not a good way to find that particular mentor. It's just that you have to go through a lot of processes and a lot of interviews and things like that to find out a mentor that will actually support us. So the best way to find out like who is a good mentor is to actually look at the mentees that they have mentored and where they have went, and always try to talk to those mentees in terms of how their mentor was, and so that will give you an insight about their mentors. And if the mentor has a lot of mentees, and they have been doing good, that is a sign of a good mentor, that's for sure. But at the same time, do reach out to mentees to see how the mentor is, and that's the best way to find out who the good mentors are. But it's a difficult task to find a good mentor, but you have to spend some time. But if you find a good mentor, certainly you'll benefit a lot in your career.
Definitely, Dr. Moudgil. I must agree with that. Getting into research is extremely interesting, but finding a mentor is the most challenging yet the most rewarding task. So for now, the very final question, I will be passing the mic over to Ahmed.
Thank you, Muskan. Hello, Doctor. Thank you so much for your presentation. We're really happy to have you here, and it was really eye-opening. As for my question, for our more junior attendees just getting into research in medicine, what inspired you to pursue this field? Has it been everything that you had initially anticipated?
Oh, yeah. So the thing is, when I started research, I used to do research in ischemia reperfusion quite a bit. And when I look at my research, so I started in basic science research a long time ago, back in 1996. So I used to do ischemia reperfusion a lot on rat hearts and things like that, on an organ model system. And then I switched my gear for the master's, in which I looked at so initially it was metabolism, then I looked at the angiotensin converting enzyme as a part of my master's, and for my PhD was totally different, which was potassium channels in pulmonary hypertension. And then when I was doing my residency, I was doing a lot more with the stem cells and the heart. And then when I matched, when I wanted to do my fellowship, it was cardio-oncology. So my career has been gone through a lot of changes like that. But one of the best thing is that, I'm very glad that I became part of cardio-oncology, is because, as I mentioned, there's a lot of things that still remain unexplored in cardiology. There's heart failures which are reversible. So, for example, if you have Takotsubo's cardiomyopathy, some of it is reversible. Some of the heart failure, if you give left ventricular assist device, they're reversible. But we haven't identified what are the mechanism of reversibility. But with trastuzumab, we are finding patients develop heart failure. And when you take the trastuzumab off, a lot of patients actually go back to their normal cardiac function. So there's a lot of things that remains unexplored. And thing is, with this oncological medications, we can actually dive into it and try to identify the mechanisms that are present and see if that is beneficial in terms of cardiovascular diseases. And that, I think, is very, very great. There was a paper published by UVU in 2019, and somebody wants to let me know. And in that one, what they did was they looked at ERB2 receptor, which is actually where the trastuzumab act. And they gave a ligation, and they took the LAD, they ligated it, and then what happened is that the heart underwent myocardial infarction. And what they did was they activated this enzyme that was only identified after the use of trastuzumab, that it causes heart problem. When we start looking at, this mechanism exists in the heart also. When they activated that receptor, it turns out that the heart was able to mend itself. Like it was able to form myocardium, it was able to form the blood vessels and all these things. And actually the ejection fraction improved in these mice. And that to me was staggering at that time, because we were working with stem cells, and stem cells were not working out very well. And here you have mechanism where you just activate it and the heart heals itself. So it was really, really good. And I think that's the most fascinating part of the cardio-oncology, is the things we don't know is becoming more apparent, and using those things to actually, identifying, things that remain unexplored in cardiology. I think that is the most fascinating part of the cardio-oncology. And I can't wait for what the world, what it holds for next 5 years, 10 years, and 20 years, because I think we're going to find a lot more about cardiology just because you're in this realm of cardio-oncology.
Wow, Dr. Moudgil, thank you so much for that amazing answer. What an amazing way to end our Q&A session. I wish we could go on. However, we are reaching the end of our session. So thank you so much again, Dr. Moudgil, for the wonderful lecture. And on behalf of everyone here at Clubhouse, we are incredibly grateful to have you here on MedNews Week.
Okay, thank you very much for having me. I really appreciate it.
Thank you, Doctor. I cannot wait to rewatch the session along with the others. So thank you again to all our panel members and attendees from all different platforms for your participation and your questions. If you missed this lecture, fret not. You can replay it here on Clubhouse or on YouTube as well. So Gayatri, do you have any final thoughts?
No, thank you so much, Doctor, for everything, for this amazing talk. I really learned a lot. And thank you, Muskan, for being an amazing moderator over on Clubhouse, taking care of everything there. Thank you again. Thank you to everyone who attended. Thank you so much.
Thanks for having me. Bye.
Yeah.
Can you
Bye,
see
Dr.
the
Lachman.
stream? On top. 1 second. And the stream.